In this lecture, we will discuss second-degree AV block Mobitz type 2, including its mechanism, EKG features, potential causes, and clinical significance. Second-degree AV block Mobitz type 2 is characterized by intermittent non-conducted P waves without prior PR interval lengthening. In other words, there are normal constant PR intervals when the P waves are conducted, and then all of a sudden there's a dropped beat. So if you look here, we have our normal PR intervals, which are, remember, the PR intervals from the beginning of our P wave. So if we draw our complex out here, okay, here's our P wave, our QRS complex. We're looking at, remember, most of AV nodal conduction is represented by this PR interval, which is from the beginning of our P wave to the beginning of our QRS complex. Normal should be between 120 and 200 milliseconds, or 3 to 5 small boxes. And we see that here. So there's normal conduction from here until there, okay, in our PR interval, and we see that throughout as we see these. And then all of a sudden, okay, we have these beats that are conducted, and then a dropped beat, okay, and then a conducted beat, and then a dropped beat, okay. So they're just dropping all of a sudden, but again, we have these constant normal PR intervals. The sinus node continues to fire normally, so the P waves continuous at a constant rate and at normal intervals. So we have normal P to P intervals, which we see here. So from this P wave to the next P wave, okay, they're constant throughout, always P waves that are occurring at these constant P to P intervals. In addition, the R to R intervals surrounding the dropped beat or beats are an exact multiple of the preceding R to R interval. Okay, so our intervals are not changing. Here's a one R wave to the next before, so here's a dropped beat. The R to R interval before that is from here to here, okay, and we're saying that the next R wave should appear at this point, okay, but it doesn't. But the one that follows continues on it. It's almost like compensated for and falls at its normal place, okay? So again, our intervals are still the same because our sinus node is continuing to fire, so we see our P waves there. We're just having these beats that occur and get dropped all of a sudden. All right, so second-degree AV block Mobitz type 2 is the result of a conduction failure at the level of the His-Purkinje system. That's below the AV node. That means it can involve the His bundle, the bilateral bundle branches, the right bundle branch and the left bundle branch, or all three fascicles. That means the right bundle branch, the left anterior fascicle, and the left posterior fascicle. So just to review our conduction system, remember we have our sinus node up here in the upper right atrium, then we have our internodal pathways and our Bachmann bundle, and then we have our AV node, okay? From our AV node we have this His bundle, okay? And then we split off into our right bundle branch and our left bundle branch. The right bundle branch continues around and innervates the right ventricle. The left bundle branch splits off into a left anterior fascicle and a left posterior fascicle. So we're saying that the level of this conduction failure can happen at a few different areas, okay? It can happen here at the His bundle, okay, that's one area, or it can happen at both the bundle branches, so both the left and right bundle branches, so that's the second area, somewhere in here, okay? So let me just erase that so we can see this, all right? So the first area is the His bundle, which is this one here. The second area is at both bundle branches, the right and left. And the third area can include all fascicles, okay, where we have this left anterior fascicle involved, the left posterior fascicle involved, and the right bundle branch involved, okay? So we call that trifascicular block. Now, in terms of causes of this form of AV block, it may be due to an anterior infarction, secondary to septal infarction with necrosis of the bundle branches. Remember, our bundle branches are pretty much the ones involved. It may be due to idiopathic fibrosis of the conduction system, okay, and there's some like Lev's disease is one of those that we have this idiopathic fibrosis of the conduction system, and it can block and prevent conduction through to the ventricles. We can also have cardiac surgery that leads to this, often when we have surgery near the septum, okay, in like mitral valve repair. Our mitral valve's over here on the left side, okay, and sometimes when we repair that, we can get this AV block, this Mobitz type 2 resulting. There could be result from inflammatory conditions such as rheumatic fever, Lyme disease, myocarditis. There's also autoimmune conditions, lupus, systemic sclerosis. You can also have infiltrative myocardial diseases like amyloidosis, sarcoidosis, or hemochromatosis. Hyperkalemia can result, okay, so if there's high levels of serum potassium in the blood. you can have this also resulting from that. Even medications such as beta blockers, calcium channel blockers, digoxin, and amiodarone can lead to this form of AV block. Now, clinically speaking, Mobitz type 2 has a greater risk of hemodynamic compromise, severe bradycardia, and progression to complete heart block compared to Mobitz type 1, right? Remember, we said Mobitz type 1 is often benign. You don't tend to have that hemodynamic instability, and they tend to not really need treatment. In addition, these Mobitz type 2 patients tend to require cardiac monitoring, okay? They have to be admitted, they need temporary pacing, and eventually placement of a permanent pacemaker, okay? So that was not really what we saw in Mobitz type 1, but here you can see that this type 2 is much more severe and could be life-threatening. Now let's go through our chart here and look at the EKG features. So in terms of the regularity, we see this is a regularly irregular rhythm, okay? And because even though we have regular intervals throughout, we do have this drop beat that really does mess up our R to R intervals, okay? So that's in regularly irregular rhythm. Our rate depends on whatever the underlying rhythm is. What is our sinus node firing at? That may determine the rate. In terms of the P waves, okay, if it's coming from the sinus node, we should have the same morphology and axis. There's no really issue coming from there. Remember, a problem is in this region. In terms of the P to QRS ratio, okay, this will vary. It could be this X to X minus 1, and what I mean by that is this first X represents our P wave, and the second X minus 1 represents our QRS complex. So if we were to look at this here, let's just erase all this so we can look at this clean. All right, so in terms of the P to QRS ratio, in this case, we have 1 P wave, 2 P waves, 3 P waves, okay, so 3 P waves, and if we were to use this equation, 3 minus 1 equals 2, so it should be 2, and we do have that. Here's the first QRS, the second QRS, and then a dropped beat, so that's 3 to 2, okay, and you see that again, 1, 2, 3 P waves, and then only 1, 2 QRS complex with the dropped beat after, okay. Now this doesn't always happen. You could have it where there's no pattern whatsoever, or it could vary between a 3 to 2, 4 to 3, or 5 to 4, or it can just go back and forth, all right. In terms of the PR interval, remember we said this is normal and constant, okay? So our problem is at below the AV node, so we tend to see a normal PR interval that's constant throughout. Okay, so all of these PR intervals are constant. And then in terms of the QRS interval, notice here that we're looking at narrow QRS complexes. Okay, I'll erase this so you can see it. So we have narrow QRS that are normal duration. Okay, so narrow QRS complexes when the beat is conducted through. And if that's the case, that means the block was within the His bundle. Okay, within the His bundle, meaning that it occurred higher. Okay, so remember our His bundle would be in this area. So if the block occurred here, you can still have a junctional escape rhythm or something coming through there where we'd still have a narrow complex occurring. Okay, and that's why we see these narrow complexes. Now if it was below the His bundle, okay, sometimes you can see those wide complexes occurring. So if you have a block down in this region, okay, you could have a wide complex occurring in those cases. In terms of grouping, yes, we said there's grouping. We saw that grouping when we talked about these, and then a dropped beat. Okay, you can have that consistently throughout, but it can also vary. And obviously there are dropped beats in this case. Okay, there's one thing you need to realize. If every other QRS complex is dropped, okay, and there are never two consecutive PR intervals in a row, therefore it's not possible to determine whether you're dealing with a second degree AV block Mobitz type 1 or type 2, and it leaves us with not knowing where the site of the block is, okay? In other words, if you have a QRS complex, so we have a complex that's conducted through, and then we have a dropped beat that doesn't occur, and then we have a complex that's conducted through, and then a dropped beat, we cannot tell if this is Mobitz 1 or Mobitz 2, because in Mobitz 1 we're looking for that lengthening of the PR interval, okay? But we're not sure if that's occurring if it's if it's dropping every other beat, and we can also not tell if this is Mobitz type 2, all right? Now, one other thing is, this is the second degree AV block can be dangerous if there's multiple dropped beats for every conducted beat, okay? And this is typically referred to as a high grade AV block, okay? And this is often due to a lesion below the AV node like Mobitz type 2. This is important to be aware of because it's a common precursor to third-degree AV block or a complete heart block, okay? So what I'm saying is if you have a beat that's conducted through, all right, then you have a drop beat and another drop beat and then one conducted through and then it dropped, and maybe dropped even again. This is something that you should be aware of. It could be really life-threatening and can lead to be a precursor to third-degree or complete heart block. All right, let's briefly review what we discussed before we end. So the main features here of second-degree AV block Mobitz type 2 is that we have these intermittent dropped QRS complexes because we have non-conducted P waves without prior PR interval lengthening. Okay, we have constant normal PR intervals. We're just having these beats that drop suddenly. Okay, remember Mobitz type 1, we had that longer drop, right? That Winky box sign. So the PR intervals would lengthen, and then drop, and that was due to that AV nodal fatiguing. In this case, we don't have that. We have normal PR intervals, and then all of a sudden we have a drop beat. The conduction failure is with the His-Purkinje system, okay, below the AV node. Here's our AV node. We're saying that the problem is below it in this region here, okay. It could be at the His bundle, the bundle branches, or it could be all the left posterior and anterior fascicle as well as the right bundle branch, okay. So it can include all those. We mentioned a number of causes that are listed here. We also said that this is more clinically significant than Mobitz type 1 because these patients can have hemodynamic instability, they can have severe bradycardia, and this can progress to complete AV block. Most of them need temporary pacemaking or temporary monitoring, as well as a permanent pacemaker placed in the near future, okay? So that's really important to be aware of. In terms of all the things, the main thing I want you to take away here is that the PR interval is constant and normal, okay? And then you just suddenly have these dropped beats, okay? Now, whether the QRS interval is normal or prolonged depends on where that block is taking place. All right. Well, that's the end of this lecture. We discussed second-degree AV block Mobitz type 2, including its mechanism, EKG features, potential causes, and clinical significance. I hope you learned something.